So when we do a root canal procedure, we have a few goals that we're trying to achieve. First, we want to mechanically debride those canals. Then we want to chemically irrigate those canals. And then we want to have a complete obturation of those very same canals. The ultimate goal of root canal therapy is to prevent or to treat periradicular periodontitis. Mechanical debridement combined with chemical effects of irrigants, such as sodium hypochlorite, is sometimes referred to as chemomechanical preparation or biomechanical preparation. And the goal of chemomechanical preparation is to mechanically instrument the tooth to remove any type of bacteria or infected dentin inside that tooth. But it's also a goal to prepare that tooth enough so we can actually get the chemical irrigants far enough into that canal and deep enough into that canal to actually further reduce those bacteria counts. To help ensure that you're adequately cleaning the inside of the tooth, how large your final apical diameter is of your final file, it's very important to determine for every tooth that you treat. So a review of literature will show that there's some controversy among providers in how they actually determine that final diameter for the canal preparation. Now, some dentists prefer to taper the canal and leave the apical area as small as possible, while other dentists actually prefer to enlarge that apical area as much as possible without actually weakening the tooth. Now, either way, one of the big goals for quality treatment and for a quality root canal is to create an access in the canal for your irrigation needle to penetrate to the depth of that working length. So the apical third is where the largest amount of bacteria reside inside that tooth, and it's also where disinfection is the most critical. Now, the wider the preparation of the canal, the more likely you will get the irrigants, those antimicrobials, to that working length. So one issue with determining your final apical size is that the canal itself is not round, right? But our files that we use are round. So that can be a little bit difficult, and it makes things a little bit somewhat subjective. So some clinicians, their approach is to basically always instrument a canal up to a specific diameter. Okay, so for example, like a molar mesial buccal canal, they may instrument that up to like a 35 file. And the distal root or a palatal root of a maxillary molar, they may instrument that up to like a 45. So, that's fine, but that can't be a hard and fast rule every single tooth that you treat, right? Because not every tooth is going to be the same. So you can't apply those generalized numbers to every single tooth that you do a root canal on. Many clinicians will actually say they take a file to working length and they continue to enlarge that apical portion of the tooth until they feel that the file is binding a little bit in the canal or it feels a little tight. Now, in those situations where it feels a little tight or it's binding, then most likely you're cleaning that apical canal space more efficiently than you would be if the file feels loose or it goes to length very easily. So when you take a file or you take a rotary file to the working length and it feels really tight in that apical third, you really don't want to actually enlarge that canal space much more than that current size, because there's always a chance that as you enlarge that apical third, you could actually be weakening the tooth as well. So a study this month in the Journal of Endodontics, they actually wanted to look at how the final apical diameter and the use of different types of irrigants affects the bacterial load inside that tooth. Now in the study, they did retreatments on teeth that actually presented with chronic apical periodontitis. So that means that the teeth were actually kind of a failed root canal and it had a periapical radiolucency around that root. Now, in the study, they removed the existing obturation material and they re-instrumented the teeth with the TF Adaptive System. Okay, the TF Adaptive Rotary System. Now, they did DNA extraction at various points in this study after specific files, after specific irrigants were used, and they basically wanted to analyze the bacterial load in that apical third. So let's talk a little bit about TF Adaptive real quick, just so you know how the rotary system works and what it is. So TF Adaptive is actually made by Kerr Dental. Okay, so once again, I don't have any affiliation whatsoever with that company. I have no ties to the company or to their products. I have used the TF Adaptive system, and I did like it. I thought it's a really slick system. It's really easy to use, very user-friendly. I mean, so much easier than some of the systems I've used in the past. So I do give them kudos and props for that. But other than my experience with that system, I get nothing for talking about this. So when we talk about TF Adaptive, the TF actually stands for twisted file, okay? So the unique thing about their files is to get the actual shape of that rotary file, the files are actually twisted. Now, a lot of files, instead of a twisted mechanism, they actually get the shape of the file by grinding on that file and basically kind of removing some of that file structure. Now, when you grind on a nickel titanium file, it's been shown that it could potentially induce microfractures in that file and could eventually lead to that file breaking or fracturing in the tooth during use. So another unique thing about this system is the TF Adaptive system is actually a reciprocating file system. Okay, so what does that mean? So if you look at a lot of rotary systems, some of the rotary systems, when the file is turning, it's constantly going in one motion, okay? When you put it in the canal, it's constantly turning in one motion. Now the unique thing about this system, the TF Adaptive system, is when you're using the file and it doesn't have any stress on the file whatsoever, the file is actually turning in a clockwise rotation. Now, when you stick the file in the tooth and it begins to cut dentin and it engages the inside of that canal, it's going to actually, get strained a little bit. It's going to get some stress on it. It's going to feel some resistance. When that occurs, the file actually adapts, okay? Hence the name TF Adaptive. It adapts and it begins to rotate counterclockwise, or it reciprocates. So what happens is you're using this thing and it's constantly going clockwise and counterclockwise throughout that whole process. And so the design there is actually to help reduce stresses on the files and to prevent file separation. Now, part of this technology is made possible because you use the TF Adaptive system with the Kerr Elements motor, okay? And that specific motor system does offer reciprocation. So from a user perspective, TF Adaptive is very user-friendly. It basically has 3 different files in 2 possible sequences. Now it's set up like a traffic light. So you start with a green file, you then progress to the yellow file, and then to the red file as necessary, depending on the size of the canal and how large you want to make that canal. Now the cool thing is all those colors, the green, yellow, and red, all correspond to the same size in paper points and gutta percha. They even sell obturators if you want to use obturators to seal the canal. So the color system, or that color coding system, it really blends well from the files all the way down to your paper points and your gutta percha. So when you're using the TF Adaptive system, after you get your access to that pulp chamber, you're going to basically, determine your working length. You're going to fill that chamber with sodium hypochlorite. And then it's best if you use some type of chelating agent, such as like slick gel or RC prep on the actual file. And after you've determined your working length, you want to enlarge those canals a little bit before you introduce that rotary system. So you're going to start with hand files, and you're going to hand instrument starting with an 8 file, then you're going to move to a 10 file, and then work your way up to a 15 file all the way to working length. And the whole time you're working on this and you're using the hand files and then eventually the rotary files, you need to keep the patency of those canals. So it's best to use an 8 or a 10 file as a patency file and extend that file 1 millimeter past your working length to help remove some of the apical debris that tends to build up during that procedure. So by using the hand files, it's kind of multi-purpose. You start with the hand files and you help develop a glide path, okay? So you're working from that 8 to the 10 to the 15, you're developing glide path, so when you switch to the rotary files, you've already created a channel or a pathway for those rotary files to follow. But the other unique thing is when you use those hand files, you actually get a lot of information from that, and it helps you determine which of the two TF Adaptive sequences you're going to use. So for example, the 15 file is the last hand file that you use. If you take that 15 file to working length and it fits really snug in that canal and it feels like it's really kind of hard to get to length, then you're going to choose the TF Adaptive sequence that is a small medium file sequence. And then that small medium sequence is going to be, again, green, yellow, and red files. Now if the 15 hand file goes to working length and it's loose, it goes to working length very easily, then your canal is a little bit bigger. So at that point you want to actually choose the TF Adaptive medium large sequence to instrument for your rotary. So once you've chosen your sequence, small, medium, or medium large, you begin to go through that green, yellow, red sequence of files. And so as you're using the rotary and the file starts to engage the dentin at that apical third, you could theoretically stop at that first file that you begin to engage the dentin in. You're actually cutting that dentin in the apical third. However, if you go to working length and you're not really feeling like you're getting much resistance or you're really not cutting much in that apical third, then you go to the next file in the sequence. So back to the study we're talking about. So they use the TF Adaptive system, and after the first file, the green file, they tested the bacteria inside the tooth. Then after the third file, they also again tested the bacteria inside the tooth. Now in some samples, they irrigated with saline after both files were used, and they tested the bacteria. And then other samples, they actually irrigated with sodium hypochlorite, and then after those files, they tested the bacteria. So after instrumentation and irrigation of all the samples they looked at, all the samples showed a reduced amount of bacteria. Now the larger apical diameters, using the largest TF Adaptive file, the red file, showed less bacteria counts than the smaller apical diameters using the TF Adaptive green file, or the smallest file. Now many previous studies have actually shown that larger apical diameters lead to reduced bacterial counts. And this really makes sense because as you enlarge that apical third, you're removing more and more dentin and more bacteria circumferentially inside that root canal. So the study also showed that larger apical diameters coupled with sodium hypochlorite irrigation had the best bacterial load reduction compared to smaller apical diameters with sodium hypochlorite irrigation. So, I mean, that just goes to support that larger apical diameters not only mechanically debrides the tooth, but it does allow you to get your irrigation needle and those irrigants deeper into that canal and to properly disinfect and be used as that antimicrobial in that apical third. So no matter if you're using hand instrumentation or if you're using rotary files, for your root canals, you really should ensure that you're trying to get your irrigation to that working length. And be sure to use a side vented irrigation needle because it's really a lot safer than a needle that expresses sodium hypochlorite out the tip, because the side vented actually shoots it out the side, so it's less likely to go out into the apical tissues. And it's also less likely to cause sodium hypochlorite injury. So if you'd like some more information about the TF Adaptive system, I actually link some of their videos on YouTube down in the description, so I encourage you to check those out. Really pretty cool. The videos really go through the system really well. They describe how to use it, the techniques for instrumenting those canals, and going through those sequences.